All right, for the sake of time, I think we'll go ahead and get going. Thank you everyone who has joined us today. I'm going to go ahead and share some slides here. We'll just run through some intro stuff and then we will pass it over to our speaker for today. Okay, we all seeing that slide? Okay, awesome. So thank you for joining. It's the last PCBH SIG meeting for the year, so we're happy to have you all here. We'll just kind of run through some initial announcements, pass things over to Dr. Cordova, and then we'll wrap up with some closing remarks at the end. Does anybody have any job announcements to make as we get started today? Anyone want to give a shout out? Well, there was just one posted, I think one today or yesterday, one came through the CFHA listserv. So if anybody is looking, you'll find some stuff there. If you've got positions you're hiring for, always good to toss those out to the CFHA job posting board. So again, as I mentioned, this is our last meeting for today. We're going to be talking about perinatal mental health. We expect an awesome presentation and some good discussion. So thank you again for joining us. We are actively recruiting right now for some leadership positions within the SIG. Super fun committee to be a part of. We do lots of awesome stuff throughout the year. So we are trying to recruit 2 co-chair positions for a 2-year commitment, and then also an early career representative, which would be a 1-year commitment. So if you have any questions about that, feel free to reach out to us, or you can scan that QR code and submit an application if you are interested. We also are still running our mentorship program. So if you either need a mentor kind of within the PCBH world or would like to be a mentor, there are lots of options available for that. I participated in that program. It's really special, a really cool thing to be a part of. So please utilize that service and resource as needed. And then if you ever have any feedback that you'd like to share with us, we're always hoping for that, really appreciate that. Feedback is love. So if you have any thoughts that you'd like to share with us, please go ahead and scan that code and send your thoughts our way. And then again, we're welcoming Dr. James Cordova today. Dr. Gray could not be with us, but Dr. Cordova is going to give an awesome presentation on perinatal mental health. So I'm going to stop sharing here quick. Dr. Cordova, you can pull up yours to share, and then I'll read your bio, kind of do a little brief intro here while you're getting set up. So Dr. Cordova is a psychology professor at Clark University and is the director of the Relationship Checkup program, which he developed as a preventative health measure for relationships, similar to an annual physical checkup. Dr. Cordova also co-founded Aramu Inc. To extend the checkup to both military and civilian populations, training over 2,000 military and family counselors. He has overseen the adaptation of the Relationship Checkup into checkups geared toward family resilience, perinatal care, and couples facing cancer. So again, thank you so much for joining us today. We're really excited to have you here, and please take it away.
All right. Thank you, Emily. And thank you all for inviting me and for being here, especially for those of you that leave your cameras on, because it is helpful to see faces and reactions and know that I'm not just speaking out into the void. So yeah, today I want to talk together a little bit about the work that we're doing to re-envision perinatal relationship healthcare in particular, in the context of the work that we're doing with the relationship checkup and a relationship checkup healthcare model. So, yep, that's us. That's me. So I'm, again, Dr. James Cordova. I am a professor at Clark University here in Worcester, Massachusetts. I've been here for 20 some years, and the relationship checkup and its sort of offshoots have been my the sort of centerpiece of my research work for the entire time that I've been here. So this stuff is near and dear to my heart. And Dr. Gray, who couldn't be here today, is my frequent collaborator. So why are we here? We're here because we want to change the entire way that we think about approaching relationship healthcare from an approach that couples use, families use sort of only as a last ditch, pain driven tertiary care model, like when everything's really hurting. Then after we've waited for a really long time, maybe we go see somebody about it, to something that's much more whole health oriented, focused on helping couples in a more proactive sort of public health frame, to live longer, healthier, more vibrant lives together from the beginning. So we're wanting to sort of shift this model from a tertiary care model to one that is more like the other approaches to healthcare. That has early intervention, primary prevention, regular checkups, and of course, always some level of tertiary care. So our agenda for today, we're going to talk a little bit about the call for regular perinatal relationship healthcare, why we feel like that's important. An overview of the relationship checkup process and some of our research outcomes. And finally, the role of attachment injury, and the relationship checkup's theory of intimacy. Our work is intended to be widely inclusive. We've conducted our studies with a wide range of couples. It's available for all couples at any stage of relationship and in any form. So if you are in a long-term committed relationship, and I guess in this case, if you are passing through the perinatal period, then the checkup is for you. Okay, part one. I want to talk about this way of framing relationships as relationship health, and the frame that relationship health is public health. So sort of bottom line up front, I think a lot of the way that we generally think about relationship well-being is in terms of like relationship satisfaction, right? Like it's good if you can get it, but like it's the icing on the cake, not necessarily the cake itself. And the argument that we're making is that relationship health should be treated as seriously as we treat physical health and mental health and dental health, that it actually is a significant aspect of our overall health systems and should be a significant part of our healthcare system. And I'm going to make the argument for why we think that's the case based on the research literature that's already available. At any one moment in time, 30% of all US relationships are significantly distressed. And by significantly distressed, we mean not like, we fight sometimes, but like it is causing significant physiological stress on a regular basis to both members of the couple and to members of the family. What we know from research is that people will will sort of live inside a significantly distressed relationship for 4 to 6 years before they even begin to contemplate going to seek any kind of help. Sometimes that help is going for tertiary care. Sometimes that help is like going to see a mediator or a lawyer, but people will live inside of a very painful relationship experience for a long time before they even begin to seek care. And what we know is that that level of distress is associated with an increased risk of suicide, increased risk of intimate partner violence, higher rates of like pick a mental health disorder, depression, PTSD, alcoholism, anxiety, like a rising boat raises all tides and a lowering boat lowering tide rate lowers all boats, right? Like, so and this is sort of the heart of it, right? Like with our relationship health go all the other health systems. So higher rates of mental health disorders, compromised immune system functioning. There's some really fascinating work that's been done that shows that partners who are in distressed relationships actually have less well-functioning immune systems. We get sicker easier, we recover less quickly, we heal less quickly. Honestly, the little ends of the telomeres erode more quickly, so we age more quickly when we're in a more distressed relationship. Overall, again, relationship health interacts in a very direct way with all the other health systems. Of course, what we know, negative child outcomes are associated with relationship uh, uh, distress. And according to one RAND study, billions of dollars in costs to society based on all of these things. So our orientation is that preventing relationship distress can prevent a range of psychological, behavioral, and physical disorders for the whole family. So just to dig in a little bit on a couple of these points, relationship health and suicide, 80% of people who leave a note in a completed suicide cite a failed relationship as one of the primary reasons. And risk factors for suicide are highest among those with low relationship satisfaction. In fact, this was sort of my introduction to the whole field. When I was in college, I worked for a suicide prevention hotline. And after I'd been there for a couple of years, I sort of worked my way into a position where I was responsible for keeping track of the reasons that people were calling into the hotline, keeping those statistics so that we would know where to, how best to use our resources in terms of training new people. And month after month for the couple of years that I did this, by double digits, the leading reason that people were calling into the hotline was relationship issues. So at that time, as I was sort of transitioning into being more interested in psychology and clinical psychology, I was thinking, wow, if you really want to have an impact on the quality of people's lives, it looks like paying attention to their relationships might be the place to go. Just a couple of the things that we know from the literature about the association of relationship health and mental health. Take, for example, substance abuse. Poor relationship health has been shown to undermine effective treatment, so much so that some folks are starting to say that to treat substance abuse disorders without, in some ways, including the significant other, it doesn't work as well. It's akin to malpractice, right? Because like the quality of that person's relationship is never neutral. It's either a force multiplier in terms of improving outcomes, or it's a detractor in terms of undermining the effectiveness of substance abuse treatment. So it's either helping or it's hurting. It's never neutral. In terms of depression, this is probably one of the most consistent findings in the literature, that as relationship health and relationship satisfaction goes, so do depression scores. So the healthier a couple is, the less depressed the individuals are. The more unhealthy the relationship is, the more depressed the individuals are. Poor relationship functioning is associated with the onset, the course, and treatment of depression. And the checkup, these sort of brief checkup style interventions, have been shown to have a significant effect on depressive symptoms. We'll show you some actual data about that later. And then just as another example, PTSD, the association between PTSD and relationship health appears to be bidirectional. So relationship health can make PTSD worse. And of course, worsening PTSD can have a detrimental effect on our relationship health. Relationship satisfaction, though, seems to positively predict decreases in some of the particulars inside of PTSD, like reliving the trauma, emotional numbness, and irritability. So to the degree that we can strengthen and enhance the quality of a partner's relationship, we can have a positive sort of indirect effect on their experience of PTSD. Like I said earlier, some of the more fascinating research in the literature is on this effect of relationship health and physical health. Studies have shown this robust association between the two. There's great studies where most of this is done by Janet Keycote Glaser. They get a couple in the room. They actually put in like a line into their vein so that they can take regular blood draws. They have the couple face each other, and then they, through questionnaires, sort of ask them, what are some of the biggest areas of concern in your relationship? Once they've sort of discerned those, they say, over the course of the next 10 or 15 minutes, would like the two of you to try to work towards some resolution of this money problem or child rearing problem or household chores problem, which is really just the sneaky way that psychologists get couples to fight on camera. And of course they do. What Janet's team then does is take like a blood draw before, while they're filling out questionnaires, during, while they're having the conversation, and then after, once they've started to settle down after the conversation. And then what you can do is you can challenge those blood draws. You can challenge the white blood cells in there by adding in a virus or a bacteria and seeing how they respond. And what they're able to show is that the like the killer T cells just respond much less aggressively in couples that have more distressed and distressing relationships. As this research has sort of evolved over time, what they've sort of discovered is it's all mediated through the fight or flight response, right? So that stress, like when we talk about a distressed relationship, it seems like it's all psychological and emotional, right? But in actuality, distressed relationships frequently trigger cortisol and other stress hormone release into the system at a much higher rate than non-distressed relationships. Those stress hormones are actually corrosive, like they have almost like a sandpaper quality to them, so that when they're passing through the vascular system, they abrade the walls of the cardiovascular system. Those abrasions are sticky. Platelets stick to them. You create like clots, right? So it has a direct effect on cardiovascular health, increasing our risk of stroke and cardiovascular disease, and just generally being overall physically bad for us, as it turns out. Okay. So also relationship health and child outcomes. This is stuff that's easy to find in the literature. Relationship conflict and divorce have been robustly associated with poorer child outcomes across all measures of functioning. The effect size is relatively small overall, but it is consistent and has been for decades. High relationship satisfaction is associated with greater child attachment security and better overall child functioning. And evidence suggests that parents' relationship quality and children's behavioral problems are also reciprocally related. So they both affect each other in this bidirectional way. What we know from this literature is that, again, it's not so much divorce that is negatively associated with child outcomes as it is how the degree to which children are exposed to conflict. So if there's a lot of conflict, open conflict in the relationship, and divorce actually diminishes their exposure to conflict, then children actually seem to do better post-divorce. Unfortunately, it just tends to be the case on average, averaged over whole populations, that divorce increases the amount of conflict that children are exposed to, and therefore that seems to be the mechanism by which divorce and separation have their most direct effect on that negative effect on child outcomes. So this is from one particular paper, 2017, by Van Scheppingen and colleagues. Just sort of a meta-analysis, a overlook of the overall literature that has shown this association over and over again between relationship satisfaction across and the transition to parenthood. So how relationship satisfaction on average changes across the transition to parenthood. And again, on average, relationship satisfaction tends to diminish quite measurably across the transition to parenthood. The top line here is first pregnancy. This is for women. For men, there's less research, but the data tends to be similar, that satisfaction tends to diminish quite measurably across this transition, this perinatal transition. Second pregnancy, it starts lower, but also tends to diminish even more. You get sort of this place of diminishing negative returns, I guess, over time. Overall, the inclusion of this graph is just to demonstrate that the perinatal period is a time of increased risk for couples in terms of their relationship health, and therefore, given what we just saw, if relationship health is deteriorating for many couples across this transition, then so is mental health, physical health, and the potential child outcomes. So given all of that, what can we actually do? Because in this period, most folks aren't necessarily, I'll take out the caveat, most folks aren't going to seek any kind of tertiary care. They're just too busy, right? Like, this is a significant transition in our lives. We don't have a lot of time to be like attending to our relationship health. We may not even really be paying any significant amount of attention to it. But that's the rub where we are right now in terms of our, let's just call it our technology within the mental health community, is that primarily what we have available to us as counselors and therapists is tertiary level care. So we hang our shingles and we wait for couples to come to us that have been in pain in their relationship for many years. And if we're talking about this transition across the transition to parenthood, it's going to be a while, right? Because again, they've got their hands full. But what we know from the research literature is that tertiary interventions for our relationship health are sought only after significant deterioration, after a significant amount of time. Distressed couples will delay treatment for years. It's often expensive. It's a significant time commitment. Any of you that actually do couples work know that how hard it can be to get two working parents into the same, even if it's a Zoom room, into the same Zoom room at the same time. You either have to work weekends or evenings, right? Because that's when folks are available, if they're available. There's a lot of social stigma to going for relationship healthcare. I think even more so than going for individual therapy, right? If I'm going for individual therapy, like at least at this point, folks are like, that's a thing that lots of people do. But I think most of us still do have that sense of like, if I'm going to couples therapy, somehow I failed, right? Like I should have been able to DIY my relationship, right? Like people that have their stuff together don't need help, right? And the argument that I'm making is that it's a little bit like thinking what people that have their stuff together shouldn't ever have to see their primary care physician, right? Like going to see your doctor means that somehow you have failed, right? We don't quite carry that stigma when it comes to seeking physical health care, but we're still living in a world in which we do carry that stigma for seeking relationship health care. Doing relationship healthcare work is a specialty inside of a general mental health care field. So there are just fewer of us that have been well trained to do this kind of work. The demand is really high and the supply is really minimal. So any of you, again, that do this sort of work will have lots of people coming, knocking on your door, calling you up, sending you emails. Do you have openings? Do you have openings? You're the 25th person that I've tried to contact and nobody's open, right? Like those of us that do this work aren't starving for work. And unfortunately for many couples, because it's years and years of accumulating damage to the relational structure before they seek tertiary care can often be too little too late. What we know from the outcome research in this space is that it's a little bit of a coin toss. 50% of couples get better and stay better, and 50% of couples either never get better over the course of therapy or get better and then relapse within the next 2 years. So it's couples therapy, tertiary level couples therapy is way better than doing nothing. And for too many couples, it's a little bit too little, a little bit too late. It's sort of like waiting to go to the dentist until your tooth has been hurting for a really long time. If your tooth has been hurting for a really long time before you go, you've sort of limited the options that your dentist has to help you. The other side of the continuum in terms of relationship healthcare or any kind of healthcare is universal prevention. And in that realm, we have relationship education. And there's lots of ways like PrEP and Prepare and other sorts of systematized interventions that have been created that are universal preventions. They tend to target the general population. They're relationship skills based type of education. What we know from the literature is that they don't tend to address the needs of more established couples. They're generally geared towards premarital or newlywed couples. And when you just sort of throw the doors open and say, come to my premarital class, the people that tend to come tend to be the people that were doing well to begin with and that were going to do well anyway. So we tend to we talk about those as like our gym goer couples. These are healthy people that do healthy things. And if you offer them healthy things, they're going to go do them. But the people that could benefit the most tend to stay away from relationship education in drove. We're not entirely sure why. I have my suspicion that most relationship education is done in a classroom setting. And those of us that actually like classrooms are an outlier. That most of the population didn't have the best time of their lives in classrooms, and so tend to want to stay away from them. What we want to do in the work that I do and the work that my colleagues do is to bridge this gap between primary education and tertiary therapy with the sort of intervention that we have in all of the other healthcare fields, regular checkups. The reason that dentistry works so that we can all get to keep our teeth so much longer than we used to is because regular checkups arrest a naturally occurring corrosive process that we can't arrest on our own. If you get in there early and often, you can keep a system healthy. If the only time that you're intervening is once the system's already become sick, it limits the amount of positive effect that you can potentially have. So how might we begin to think about implementing the kind of relationship healthcare that could be regular and repeatable? So that was the development of what we're now calling the Relationship Checkup. Originally, we called it the Marriage Checkup, and we've moved to make it as inclusive as possible. It's a simple idea. We want to do for relationship health what regular dental or physical health checkups do for the health of our teeth and bodies, with these twin goals: prevention and early intervention. So quick story. Prior to the mid 1950s, there was no such thing as regular dental checkups. Dentists were tertiary care interventionists. And it was actually the US Army that first figured out that they were like, we're losing a lot of our personnel to like abscesses and other dental health emergencies. So they determined somewhere mid 50s, early 60s to like, let's just experiment with what regular checkups might look like. And what they discovered is it makes a significant difference. And that significant health improvement then sort of bled out into the rest of the culture. I often point at Clark, there's a room that we lecture in that from one end of the room to the other is surrounded with pictures of PhD graduates from back in the 1800s to 2023. And one of the things that you'll notice in that parade of pictures is people do not start smiling in a way that shows their teeth until about 1964. And there's a reason that they're not smiling in a way that shows their teeth, is because prior to that, there weren't regular dental checkups, and most people didn't have teeth that they wanted to show in their photographs. And now we've sort of come to take for granted that most of us with regular dental health care get to keep our teeth, most of them at least, for our whole lives. We're sort of hoping our sort of blue sky dream is that we can have the same significant health effect with regular relationship healthcare that regular dental healthcare had for the health of our teeth. So how do you do that? We want to increase access to this regular care. Regular checkups are intended to lower the barriers to help seeking, because there's a lot of them. They're intended to be quick, 1, 2 in embedded behavioral healthcare settings. It's 3 30-minute sessions. They're intended to be quick, easy, fun. They're actually intended to be fun as well as effective. Less threatening than therapy. Like a lot of people will say, well, I was willing to do a checkup. I wouldn't have done therapy, but a checkup seemed pretty like accessible. Increase, and for folks that get a checkup, which again has lower barriers to entry, it actually increases their motivation and comfort to seek additional care if and when that additional care is necessary. So we can get people into the tertiary care that they might need earlier in the process, before hopefully they've done unrecoverable amounts of damage to the relational framework. The structure of the checkup for behavioral health, embedded behavioral health counselors, we do it in these 3 30-minute sessions. In the first session that we call the assessment session, we go over their relationship history, which is both assessment and intervention. We do an assessment of their relational strengths, again, which is both assessment and is therapeutic. That's 1 30-minute session where we're just helping them to orient towards what is best about their relationship. In the second 30-minute session, we do a therapeutic interview of the 2 primary areas of concern in their intimate romantic relationship. And then we do what we're calling sort of preparing and creating greater resilience within the attachment system as they move through that perinatal period. So we want to like strengthen the attachment, the pair bonding attachment system, so that it withstands that transition to parenthood more robustly. And the final 30-minute session, after we've created their feedback report, which now we call a pair report, because feedback can sound a little scary, is the action session. We review our assessment findings with the couple. We reiterate their need for more compassion eliciting, intimacy producing understandings of their areas of concern and their shoring up of their understanding of the attachment system in their relationship. We review a menu of options for how to move forward in an even healthier way. This is sort of the brushing and flossing of their relationship. And then they're done. We send them on their way. See you again in a year or 2 for your next checkup. Talk a little bit about the outcomes that we've seen in the research that we've done. Just check and see how we're doing for time. We've done multiple studies, several randomized control trials that have been federally funded, NICHD, ACF, the Lego Foundation in Denmark. We've done a before baby pilot study. So this sort of like we're talking about today, we've got an LGBTQ pilot study, and we did a full-scale randomized control study with the Air Force with funds from the Department of Defense. So this was the first NICHD study. This is a study over the course of 2 years. The blue line is couples that got the relationship checkup. This second boost right here is their 1-year annual checkup. So first checkup here, you see a significant increase in satisfaction that sustains, although it sort of drags a little bit here up to year 2, where they get their second annual checkup. Again, you get a significant boost in relationship satisfaction that tends to diminish a little bit over time, but still stays significantly above our waitlist control group. So you get this sort of like you're popping a balloon up in the air in terms of relationship health. Every time they come in for a checkup, they get a significant boost to their relationship health that seems to sustain but settle a little bit over time. Again, somewhat suggestive of a naturally occurring corrosive process that may have to be regularly intervened with. So that was satisfaction. This is intimacy. We actually get somewhat stronger results for intimacy. The way we measure it, intimacy is defined as the degree to which we feel safe being our authentic, vulnerable selves with each other. and it's the sort of theoretical root of the intervention that we do. So you get a significant increase in intimacy that tends to sustain. It's boosted again at year 2, again, tends to sustain with a little bit of diminishment. Interesting, and we find this multiple times in our studies. For the waitlist control group, the group without any intervention, intimacy tends to sort of slowly degrade over time. Similar sorts of results for acceptance. Our depression outcomes, like I was saying before, as relationship health goes, depression seems to follow suit. The purple line here, the purple bars here, are individuals whose score on the depression inventory were in the clinically depressed range. And it's with those folks that the checkup seems to have the biggest effect sizes in terms of diminishing depression immediately. So this is at 6 months, a 0.67 Cohen's D for reductions in depression. And part of the thing to keep in mind here is that the relationship checkup doesn't target depression at all directly. So this is all an indirect effect based on improving relationship health. So you get these dramatic increases in depression recovery. It does tend to diminish over time. Once we get out to 2 years, it's a little harder to discern the difference between all of the couples, all of the individuals, minimal depression and clinically significant depression, but you get these boosts, again, sort of like popping that balloon up in the air. This is from our ACF dissemination study. And again, we get significant effect sizes for all of these types of outcomes. The only one that we didn't was in their parenting based on the PPIC. So how satisfied they were with the parenting dynamics in their relationship, which is still a target that we're trying to hit more directly with the perinatal relationship checkup. The part of this that we usually want to highlight is that this study is one of the only studies that's been able to show that a brief intervention can have a positive effect on some of the early precursors of IPV that get picked up by the conflict tactic scale. This is from our Air Force pilot study. So this was just between baseline and 2-month follow-up on a sample of, I think, roughly 30 couples. This pilot study allowed us to get funding to do a larger randomized control trial. So this was with over 200 couples. And it's a simple line, but again, you can see relationship satisfaction for those that get the checkup increased significantly and stayed significantly more satisfied at 6 months than couples that were on the wait list and didn't receive the checkup. One of the things to keep in mind is that the folks that come in for the checkup, this was in the Air Force's primary care behavioral health care unit. So all of these are folks that got this 3-session checkup, 3-session version of the checkup. And those embedded behavioral health counselors inside of a primary care physician's office. So the couples that we're seeing here are not all distressed. It's like anyone that checked off a box that, like, I'm a little worried about what's going on in my relationship, would get warm handed off from the physician to the psychologist. And then they would go through, if they were up for it, they would go through the relationship checkup. So this includes distressed couples, what we call veiled help-seeking couples, which are couples that say, we're fine, we just thought a checkup would be awesome, but actually are struggling with some stuff in their relationship. And also couples that are still the gym goer couples. We just do healthy things for our relationship anyway. And for any kind of checkup healthcare model, you want to be able to attract that whole spectrum, from the ridiculously healthy to the maybe early intervention would be good to you, to like, oh my gosh, you're sick, we need to send you to a specialist. Okay, preparing the attachment system. Just briefly, how we think about adult attachment. Adult attachment refers to the patterns of emotional bonds and expectations individuals develop in relationships shaped by early caregiver experiences. So we develop our attachment styles in our early caregiver relationships, and then we transfer those into our pair bonded relationships. These attachment styles, secure, avoidant, disorganized, influence how adults regulate emotions, seek support, and respond to relationship challenges. Secure attachment tends to be characterized by comfort with intimacy and comfort relying on others. Insecure attachment styles tend to reflect difficulties in trust and emotional closeness. Attachment dynamics play a significant role in relationship satisfaction and resilience across life stages. The way that we're sort of thinking about the checkup in this context is that there's a significant vulnerability to the attachment system that is unique to the transition to parenthood. One of the dynamics that we're paying attention to here is a phenomenon that we call attachment injury. An attachment injury refers to a significant relational breach that damages the trust and security foundational to attachment bonds. So these are things that happen in the relationship that break that sense of, oh, I really can depend on my partner to be there for me when I really need them. These injuries often occur when one partner fails to provide support or validation during a critical moment. And the perinatal period is by definition a critical moment. So like it says here, such as significant stress or life transitions. The transition to parenthood as a major life change can and often does strongly activate attachment dynamics. So we think of this as a place where there is the potential for a perfect injury storm. For the birthing parent, there is that person is going through a profound psychological and physical transformation, which makes them exquisitely vulnerable. This is something that really activates their attachment system. It's a very fragile moment in which it's really easy for the partner to fail to meet that partner's powerful attachment needs. And most people just aren't prepared for how to show up skillfully as a secure and safe harbor during this very painful, very challenging transition. So it's really easy to create accidentally an attachment injury where the partner just like doesn't know, how do I show up in the most supportive way, in a way that helps my partner to feel safely and securely held, when I also feel like I'm a little bit in over my head. For the non-birthing parent, it's also a profound social and psychological experience crossing this perinatal period that activates their own attachment system. The birthing partner is very naturally oriented toward their own disorienting experience of giving birth, as well as the exceptionally powerful pair bonding experience with their newborn, right? And so a lot of the attention and consciousness gets drawn into that relationship with the new baby, and therefore significantly less able to be responsive to their partner's attachment needs, maybe even not particularly aware that their partner's attachment system is also significantly activated. The challenge is both partners' attachment systems are highly activated, and both parents' resources and responsiveness are significantly compromised. The perinatal relationship checkup is designed to intervene proactively during this period to strengthen the resilience of the couple's attachment system so that it survives and responds flexibly and actively across this transition to parenthood. So just quickly about vulnerability, we are born exquisitely sensitive to any signs of rejection or judgment by other human beings. Our personal vulnerabilities are those things about us that we are afraid will be judged and rejected by others. And that includes our needs for connection and soothing, which is really, at the heart of that attachment bond. When I am most desperately in need of connection and soothing, that's when I turn towards my attachment figure. If my attachment figure tends to faithfully catch me in that spot, secure attachment. If my attachment figure even one time, especially if it's a significant moment of need, fails to catch me and I fall, then that can often become that attachment injury that is hard for a couple to recover from. That's what we're trying to intervene with. So in relationships, we learn how safe we are being our authentic, vulnerable selves. Where it feels unsafe to be vulnerable, we turn away. So one of the suspicions that we have is as couples cross this transition to parenthood, there are these little moments where they miss each other in that attachment need space that sort of like corrode that feeling of trustworthiness. Like, are you really going to be there for me when I really need you? Can you really be there for me when I really need you? And in that space where we might feel like, I'm not sure I can trust you anymore, we start to turn away from each other. So we enter this relationship space with our complicated histories. They teach us how to respond to moments of hurt. And more often than not, when the initial attempt at connection fails, we turn away from the pain and then ultimately from our partners. In the checkup, we're using the couple's perpetual issues to actually turn them back towards one another and begin to build what we call intimacy bridges. We actually take the spot where they're most likely to experience conflict, and by helping them to uncover and communicate the vulnerability underlying that place of conflict, create a sense of greater safety and intimacy. So actually build intimacy bridges right in the spots where the couple feels like they might actually be at their weakest. Our jobs as counselors, as clinicians, is to find the places where partners are turned away and help them to turn back towards each other. We create this intimate safety by nurturing open communication of vulnerability. We're building intimacy bridges through compassionate understanding, helping the couple to turn toward each other in a compassionate way, allowing them to hear their own complaint, their own story, their own yearning in a softer, more loving way rather than in a complaining and harsh way, seeing each other's struggles in a way that pulls for a kinder, gentler response naturally, takes the blame off of each partner so that they can begin to approach their actual problems more collaboratively as partners rather than in opposition to each other. The three strategies in general that we use to build intimacy bridges are uncovering soft emotions, discovering understandable reasons, and identifying themes and patterns. And in there, we do some psychoeducation about what attachment bonds are, what's going to activate their attachment system as they move across the transition to parenthood, what that's likely to look like for each partner, and how each partner can notice the call for attachment connection and meet that with as much skill and a responsiveness as possible, right? So we sort of, a lot of what we do besides shoring up the intimate connection is prepare them for the fact that the attachment system is going to be going through it across this transition, and pre-warned is forewarned is forearmed. That's the saying. So that they're able to, both the birthing and non-birthing parent are able to see the other's attachment needs as they're arising and know what to do to help the other person feel like, I see you, I care about you, I'm here for you. Our mission at Aramu is dedicated to making these proactive relationship healthcare interventions accessible to everyone everywhere, right? So our blue sky vision is that regular relationship healthcare checkups will be as easy to access as dental checkups are now. So that's very much a blue sky vision because it's nowhere near that at this point. But that's what we are about. We're trying to train as many healthcare workers as we can to be able to do these empirically validated regular relationship healthcare checkups. Okay, that was as quick and high level as apparently I'm capable of. So we will stop sharing here. so that I can take any questions or comments that you all might have.
Hi, Dr. Cordova. Can you hear me?
I can, Rachel.
Okay, wonderful. Thank you so much for coming on and doing this presentation for us. If we want to know more about this relationship checkup, where can we go to get more information?
So we are now operating out of this university-based startup company. So we were able to borrow a chunk of money from the university so that we could get this thing up and running. And so you can find us at aramu.com. It's ARAMMU.com. Aramu is, at least according to Google, ancient Sumerian for love. And none of us know if we're pronouncing it correctly because nobody speaks ancient Sumerian. Some of us say Aramu, some of us say Aramu. Nobody knows who's right. Other questions or comments? All right.
Hi, good afternoon. My name is Farah Moram. I'm a licensed clinical social worker based out of Florida. And couples therapy is one of my niches. And I was trained by the Gottman Institute, and I love couples work. And this is wonderful. And I am so eager to learn more. I usually encourage my couples to do a checkup.
Awesome.
And so this is definitely right along with my belief and philosophy, and I will be looking forward to learning more. I currently work for an FQHC, which is on Healthcare Network.
Okay.
And we do have, an OB unit, and we will definitely would like to see how we can learn more and get more clinicians to be trained in this type of work. Thank you so much.
Absolutely. I really appreciate that. I mean, the goal is, like, for the most part, we're sort of leaving our couples, again, we're sort of leaving them to their own devices across this really significant transition in their lives. And like, we know from the data that so many of them, their relationship health is going to suffer across that transition, but there just isn't a lot available for us to do that they're actually going to participate in, and that we know has research behind it to show that they could benefit from. And I'm just so curious about, like, what if all couples got some kind of like preventative checkup type thing, right, as they were going across the transition, especially for the first time? Like, might that not really make a significant difference, right, in terms of how they manage that transition in a healthy sort of relationship preservative way?
Yeah, absolutely. When we think of health equity as well, and especially in the FQHC, as for me, I do couples therapy more in private practice.
Yeah.
But in the FQHC world, most of our couples can afford to pay $250 per hour.
Right.
And thinking about, equity of health. So this is huge. This is huge.
Yeah. Yeah. Actually, John Gottman was one of my professors when I was at the University of Washington. He was on my dissertation committee.
Oh, no kidding. He's a funny.
Yeah. Yeah, he's a great guy, and I love all the stuff that he does. And so I'm always encouraged to know that folks are taking advantage of the stuff that he has to offer.
Absolutely. Thank you again for this. This was an awesome presentation.
Absolutely. Yeah, thank you.
Any other questions before we wrap up? Wonderful. Dr. Cordova, thank you so much for being here with us. It was a joy to hear about this. And like Farah, I'm definitely interested in how we can use this with our patients and our populations. Just as a reminder, if anyone wants to be part of the PCBH SIG, we are currently having nominations, and you can apply to be on our leadership team. And then our next meeting is to be determined, hopefully in February of next year. But Thank you all for coming. If you need anything, any questions, email any of us at the PCBH SIG. And until next time, take care. Thank you, Dr. Cordova.
Absolutely. Thank you all.